exposure to this fetal medicine through our local boss, Dr. Verenga. It's been a pleasure working at the fetal medicine units housed at Barrenyatwa, Mbuyane Hospital, and Salim Gabe Maternity Hospital. So I'll be sharing some experience from the exposure which I've gotten, and also the critical role in which all of us should play in order to help in the care plan of these high-risk pregnancies. So preeclampsia is quite a burden in sub-Saharan Africa. So I believe at the end of this presentation or this talk, we should be able to have answered or tried to answer some of these questions, including, does preeclampsia affect fetal growth? How should preeclampsia pregnancies be monitored? Can preeclampsia be screened? Does Doppler ultrasound play any role in the surveillance of preeclampsia / fetal growth restriction? Shall see how these ones are closely linked. So some statistics from Zimbabwe. They are on the bedside because they are quite high. We've got a high maternal mortality as well as perinatal mortality. Based on the report, the annual report by the Ministry of Health in 2018, it showed that 651 out of every 100,000 pregnant women die during the pregnancy or during delivery, which is quite a sad statistic. At the same time, over here, you can see that we lose 29 in every 1,000 babies. The mothers will not go back home carrying their baby, which is also quite a sad statistic. And here we can pick that the leading cause is preterm birth at 34%. Then we've got birth asphyxia at 26%. This one is quite linked to what we'll be discussing today. Then if you look at so far, we've scanned, the number has increased, but at this point in time, we've scanned about 2,713 pregnant women, and almost a quarter of them, at 26%, had preeclampsia, which is quite huge. And another significant finding was 41% of the almost 700 who had preeclampsia, 41% of them actually had fetal growth restriction. Remember earlier on, I put preeclampsia / fetal growth restriction because they've got a great correlation and association. So I would just talk about these three broad categories of preeclampsia. We've got severe, very early onset preeclampsia, which develops before 24 weeks. Then if it develops before 34 weeks, we refer it to as early onset preeclampsia. Then if it develops between 34 and 37 weeks, it's termed preterm, late onset preeclampsia. Then sometimes it can also be discovered at term, then it will be termed term preeclampsia. So does ultrasound play any role in fetal monitoring? So I think you saw from our statistic that 41% of the 700 preeclamptic women, which we have scanned at our fetal medicine units, actually had fetal growth restriction, which means we should pay particular attention in identifying and flagging these small for gestational age babies so as to make sure that we closely perform surveillance throughout pregnancy. So this is done by measurement of the fetal biometry, as well as fetal Doppler parameters at regular intervals by ultrasound using set protocols. So ultrasound Dopplers indeed play a pivotal role in high-risk pregnancy. And our ultimate aim is to prevent perinatal death and handicap. I think you saw our statistics there on the high side, which is something which our fetal medicine units, as well as everywhere you are, you should play a role in trying to make sure that those statistics don't remain that high. So Dopplers play a variety of roles, though today I'll be mainly focusing on preeclampsia and fetal growth restriction, but they play an important role during the course of pregnancy. So the Dopplers can be used in screening for preeclampsia, as well as fetal growth restriction in early pregnancy. When we do the 11 to 13 week early pregnancy scan, we can also do the uterine Dopplers in order to predict the risk of that pregnant woman developing preeclampsia later on in pregnancy. Dopplers are also play a role in screening for aneuploidy as well as cardiac defects, mainly using the uterine artery Doppler and the ductus venosus. Dopplers also play a role in the prenatal diagnosis of conditions such as fetal anemia, whereby we look at the peak systolic velocity of the middle cerebral artery. They also play a role in the diagnosis of fetal growth restriction, as well as also in multiple pregnancy when we have got the twin-to-twin transmission, twin-to-twin transfusion syndrome, as well as the TAPS, that's the twin anemia polysystemic syndrome. Dopplers also play a role. And they also play a role in fetal surveillance. When we are doing surveillance for fetal anemia, we'll be tracking the peak systolic velocity in the MCA and fetal growth restriction. We'll be tracking the Doppler waveforms as well as the pulsatility indices of the various fetal Doppler parameters, which I'll be talking about in greater detail as we progress. All right, so at the fetal medicine, so most of the protocols that we use at our local units, the fetal medicine units, which are affiliated to Fetal Medicine Foundation Zimbabwe, which has strong backing of Fetal Medicine Foundation by our beloved Prof. Nicolaides. So we adopted and adapted our protocols from them. So you find there's a great link where we needed adjustment, we adjusted accordingly to our local needs. So currently we use weight, estimated fetal weight. If it's less than the 10th centile, then we say there is fetal growth restriction. Secondly, if there is any abnormality in any of the fetal Dopplers, the umbilical, the MCA, and the ductus venosus, we also categorize it as growth restriction. So why is surveillance important? Several studies which have been done have shown that small for gestational fetuses who undergo surveillance and timely delivery have a 4 to 5-fold reduction in mortality and or severe morbidity before birth. So you find we've got quite a critical role to play as sonographers in the care plan of being involved in such a significant reduction in mortality and morbidity. Okay. So we were talking about preeclampsia being high risk women, and that pregnancy is at high risk. So our surveillance tools include Doppler studies, the umbilical artery, the ductus venosus, the middle cerebral artery, as well as 2 weekly growth scans, whereby we are tracking the progress or regression of the various biometry parameters. We also look at the biophysical profile. The CTG currently, we are moving towards it. We currently don't have it. That's cardiotocography. So what are the surveillance goals? They include, want to assess the risk and extent of hypoxia or acidosis, want to assess the risk of stillbirth, want to assess the rate of clinical deterioration, want to plan for appropriate interval of the next visit, and ultimately want to decide on the best timing of delivery. So we don't want the fetus to stay too long or too short. So want to determine the best timing in which they have to be delivered. So I talked about surveillance growth using fetal biometry. So we use the biparietal diameter and the head circumference, and it's at a certain level, standardized level, whereby you have to see those structures to say you have obtained an appropriate head circumference. Remember, things are standardized. The femur length is also incorporated. So does the abdominal circumference with all those structures needing to be shown.
Good evening, everyone. I think our presenter maybe lost connection. I will try and get in touch with him on his mobile phone just to verify what happened. Kindly just hold on as we get him back. Thank you.
I was going to go to So the same applies for the Dopplers. I'll be talking more about the Dopplers as we proceed. They also have nomograms. All right, so on this diagram, it shows the categories of growth or the categorization of growth, whereby we've got large for gestational age. If we measure, for example, the head circumference, and it has been correctly dated, the pregnancy has been correctly dated, then we enter the parameter. It will tell us whether that parameter is large for gestational age, is it appropriate for gestational age, or is it small for gestational age? So that categorization is very important. And when we are talking about fetal growth restriction, we are mainly focusing on the small for gestational age, though you might have some fetuses who are in the appropriate for gestational age range in terms of their biometry, but as long as the Dopplers, any one of the Dopplers becomes abnormal, then we'll categorize it as fetal growth restriction, even though their weight is in the appropriate for gestational age range. So these small fetuses, the small for gestational age, 20% of them actually are what we call normal small or constitutionally small fetuses, which means is possibly some genetic disposition of the parents. They are just small, but they are not diseased. So we are not really concerned about the normal small. So you will find usually if you ask the history, or possibly when you're actually scanning, you actually see that the mother is short, and you ask also the dad will also be vertically not gifted. So if you find that the baby is also small, but everything else, the risk profiling is of that they are low risk, then you are not really concerned. Even the Dopplers will also be normal. So that's the normal small. We are not concerned. We are mainly concerned about the other 80%, which is the 15% of the abnormal small. So these abnormal small are mainly due to chromosomal abnormalities, as well as they can be due to infections such as the torches and so forth. And there are some markers which I will discuss in the other slide. Then we have staffing small, which has the lion's share, contributing about 65% of all small babies. The staffing small are mainly due to placental insufficiency, which can be linked to our preeclampsia. Then on this top left graph, it's merely showing us that in terms of fetal growth restriction, we've got two major categories. We've got what's known as early onset fetal growth restriction, which is fetal growth restriction which occurs before 32 weeks. Then we've got late onset fetal growth restriction, which occurs after 32 weeks. Just keep this in mind because we will need it as we progress. So I was talking about some of the sonographic markers of the, remember I talked about the 80%. So when you're talking about placental insufficiency, which we said is 65%, so you find you see a grade 3 placenta. You can see that it's now having calcifications, which means in terms of function, it's deteriorating in terms of its function of vascularizing the fetus. And if you do the uterine Doppler, you will see that it will be having a very high PI. You can see about these tall systolic peaks, as well as reduced end diastolic velocities here. And you can see the bumps there, which we refer to as notching. Then for the chromosomal abnormality, we know that the gold standard is karyotyping, but sonographically, possibly if you see a placenta which is crowded, large like this, almost on the hyperechoic side, with this they can be a sonographic marker for fetal growth restriction due to chromosomal abnormalities, which means if you flag it, then you can recommend if the facilities are available for karyotyping. Then if the fetal growth restriction is linked to infections. There are sonographic markers which include periventricular calcifications. You can see that ventricle, which has got some calcifications in the boundaries. Then you can see here, we've got the liver, which has also some calcifications. They are a pointer towards infection, and most likely you can recommend torch screen if it is available. All right, so I categorized that there is early onset fetal growth restriction. So in early fetal growth restriction is the one which occurs before 32 weeks. And this one is a perfusion placental defect, which can be attributed to decreased villus placental vasculature. So if it's a perfusion problem, if you do your Dopplers, you will find that it will show in the waveform of the umbilical artery. How will it show? It will show by a decreased end diastolic velocity of the umbilical artery, which corresponds to a high pulsatility index. So definitely, once you see that there is this, it shows that the perfusion is somehow compromised, and you will know. So the issue now, the catch about early onset fetal growth restriction is this. Because this one is occurring too early, so you find sometimes the weight of the baby or the fetus will be still low, so that their chances of surviving, if we make the decision to have them delivered, it might reduce their chances of making it after delivery. So what we want to try to do is to prolong their stay inside the uterus, but not to overstay, because if they overstay there, they are prone to demise. Then we'll end up having intrauterine fetal demise. So we want to look for a, you're striking a balance between when is the best timing to do it. We do not want to deliver them too early because we might lose them. We also don't want to delay their delivery because we might lose them inside or we might lose them outside. So in terms of deterioration of Dopplers, it's not an acute thing which happens like instantly. It's something which happens gradually. So you can see here, we've got about 2 to 6 weeks in the early vascular response. Then we've got about 2 to 4 weeks in the late vascular response, which means we've got some time in which we can push while closely monitoring so that we determine the optimum timing. Possibly, I would also would like to talk about, there is a study which was done, which is known as the TRAFO study, which showed the importance of ductus venosus as a determinant of decision to deliver when it's early onset. Because remember, this is a delicate time whereby the weight and the development has not progressed that much. Okay, so after 32 weeks, the dynamics change somehow. This time it's a diffusion. Remember, early onset, it was a perfusion, and it was demonstrated in the umbilical artery, showing a high PI and reduced end diastolic. However, now, when it becomes a diffusion abnormality, you can have the umbilical artery not showing any abnormality. So it might be normal umbilical artery. However, we will pick now, that's the importance why every sonographer who deals with this high-risk pregnancy should be able to competently perform the umbilical artery Doppler as well as the MCA, at least those ones, as a minimum. Why? Because even if the umbilical artery Doppler is normal, you have to further interrogate the MCA. And if you see that the MCA has now an increased end diastolic flow, is now appearing more like the umbilical, because they are supposed to be like the opposite of each other when they are normal. So if you now see that the MCA is now gravitating towards becoming the umbilical artery in its normal sense, then it's a trend which is called redistribution. Possibly, I think the common term which is used is brain sparing, whereby now the fetus is now adapting by vasodilation of the vessels going to the brain, so that the brain is given preferential treatment because we've got shortage of supply of oxygen. So we now shunt the brain to receive the lion's share. And it's also associated with a decreased cerebral placental ratio. Okay, so that's late onset fetal. So major points to take note of: early onset, it's a perfusion abnormality. Late onset, it's a diffusion. How do we know the late onset? The diffusion, it's by the reduced PI in the MCA, or reduced placental cerebral placental ratio. Okay. All right, so those are the Dopplers, the umbilical, the MCA, as well as the CTG. So what do we want to try to avoid? Because this is the part where we have to show our relevance when we are scanning. We shouldn't just scan alienated from helping in the care plan. So we want to reduce the risk of hypoxia or acidosis occurring. And this one is done by multiple modalities. It's not a solitary, but we can use the ductus venosus. It's a huge marker. You can see here there is deterioration of these aspects, and it's going towards acidosis. And acidosis, we said, is mainly due to fetal hypoxia. And one of the markers which we talked about earlier on is the reduced PI in the MCA, or as well as the reduced cerebral placental ratio. So once the baby becomes acidotic or hypoxic, usually they demise in utero, what we commonly refer to as IUFD. All right, so we as I said, we follow this surveillance and protocol, whereby you can have scenario one, whereby you have got fetal growth restriction, which means your biometry, the estimated fetal weight, is being said to be less than 10 centile, but the Dopplers are normal. If you have got that case, there's a way in which you do the surveillance. So the surveillance is done every 2 weeks. So every 2 weeks they come, you measure the biometry again, you compare to the previous one, you measure the Dopplers, you compare to the previous ones. In scenario two, you've got fetal growth restriction with abnormal Dopplers. So this time, you have got a high PI in the umbilical artery and a low PI in the MCA. So if we've got that scenario, that's the one which corresponds to the low cerebral placental ratio. So if we've got that case, we are no longer doing surveillance every 2 weeks. We are now doing it every week. Scenario three, you have got fetal growth restriction with absent or reversed end-diastolic flow in the umbilical. This one, if it's happening in early onset, we don't, it's a bit different. I want you to take note of this. If it happens in early onset, we will not make the decision to deliver, but we'll continue doing surveillance, but this time we're doing it every 3 days. Okay. All right, so when do we finally make the decision to say, oh, now you really have to take this baby out. So our main focus, so we are doing surveillance of all the Dopplers, but the one which will determine the decision to deliver when it is before 32 weeks, it's not a reversed umbilical, it's not an absent umbilical, but it is a ductus venosus when it starts showing that it is absent a wave or reversed a wave. That's when you have to, we actually recommend delivery within 24 hours or the baby will die inside so it's the same, possibly wherever you're scanning, you come across a reversed or absent a wave, you really have to take it seriously, because if you don't advise them or possibly refer, you find that the next moment they will tell you the baby has demised inside. So once we have a reversed or absent ductus venosus on the A wave, the baby has to be delivered within 24 hours. I talked about the TRAFO study. So moving on to late onset fetal growth restriction, I talked about the uterine artery. Remember when I mentioned the issue about a grade 3 placental insufficiency, that one which had calcifications. And we also mentioned that at times, because it's a diffusion problem, you may have a normal umbilical or mildly abnormal umbilical Doppler pattern. However, the abnormal middle cerebral artery Doppler, the shunting which I mentioned earlier on, will predispose the baby to possible potential hypoxia. So for late onset, the dynamics change a bit in terms of our decision to deliver. So yeah, if there is fetal growth restriction with normal Dopplers, is one which is the same as before 32 weeks, we'll continue doing 2 weekly growth and Doppler scans, monitoring. Then scenario 2, if we've got a high PI, then we'll do weekly Dopplers with biophysical profile. Then scenario 3 is when we've got a low MCA, the one which I said is known as shunting or brain sparing, or we popularly call it redistribution, as well as a low CPR. Then we have to scan them every 2 to 3 times a week. So possibly every 2 days or every 3 days. So when is the decision to deliver arrived at? When the fetal growth restriction is late onset, that is after 32 weeks. When we have a high PI in the umbilical or a redistribution in the MCA, we will aim to deliver them at 37 weeks, but we'll continue the weekly surveillance. But whenever we get the reversed or absent and diastolic after 32 weeks, we recommend delivery within 24 to 48 hours. It's a bit different from early onset, whereby we'll continue monitoring them every 3 days because our focus is the ductus venosus. But this time, when it's after 32 weeks, we actually, why? Because now they've gained sufficient weight and a bit of development. So after administration of antenatal steroids, then we can recommend delivery once we have reversed or absent and diastolic in the umbilical. And if they have got fetal growth restriction, but with normal Dopplers, we aim to deliver them around 38 to 39 weeks. That's just a summary. All right, so I will quickly rush through the technical considerations of how now to do the Dopplers, which I think you are now appreciating that they are quite a pivotal tool to use, which every sonographer should be equipped with. Okay. So for the Uterine artery Doppler, the technique can be done trans-abdominally or through the TV route. For the TV, the urinary bladder should be partially filled, and you observe the uterine artery running along the side of the cervix and uterus at the level of the internal os. Then there'll be two of them on either side. So depending on which side you are examining, you have to make sure that the probe is biased towards that side. Then you should ensure that the angle of insonation is less than 30 degrees. I think we're now applying Doppler principles using the Doppler shift frequency formula. Then earlier on, we said you can use them like for the first trimester, as well as during the anomaly scan. You can use them as a screening tool for risk profiling for preeclampsia. So if you find a high PI, you can put in the nomograms or in the calculators, and they will calculate the risk of that woman getting pregnant. Why are we just interested in just risk profiling? No, they can actually be put on administration of aspirin to help reduce their chances of developing the preeclampsia we would have risk profiled them for. So that's a uterine artery, and that's a waveform you can see that this one is normal because it has got very good anti-diastolic flow, which is what we want. However, these ones have got a high PI. You can see the end-diastolic flow is reduced, and there's also notching. The same applies to that one. Those ones are abnormal. Then so the one which runs through the cervix is usually in the first trimester as well as during the anomaly scan. However, in the late second trimester into the third trimesters, the technique differs a little bit. This one, you have to identify the iliac vessels. You see them running side by side, the vein and the artery. So the uterine artery runs 90 degrees or perpendicular to those iliacs. Then you open your sampling gate at 2 millimeters and make sure that your angle of insonation is less than 30 degrees. And what you do, you average the PI, the pulsatility index of the left side and that of the right side to get the mean pulsatility index of the uterine artery. These are some images you can see here. On this second image, you can actually see the iliac vessels, and we are seeing this one, that's the uterine artery running 90 degrees to the iliac vessels. Then the umbilical artery Doppler, it is supposed to be performed on a free loop. I think that's this one most of you are familiar with. Possibly the only addition that I can make on this one, it should be a free loop. And ideally, you have to measure until I believe we all know that we've got two arteries which coil around one vein. Preferably, you have to sample both arteries and get a mean. And make sure that you are scanning through a vertical portion of that umbilical artery. And yeah, you can see here, this is a normal with a very good end-diastolic flow. Same applies to that one. The MCA, most people are not familiar with this one, but it's not a very difficult one. From the level whereby you measure the BPD, you just you slide your probe towards the base of the skull. You identify the sphenoid greater wing, the sphenoid bone, and the MCA runs within that greater wing. And use color flow Doppler to identify it. You place it on the middle third of the MCA, and you should ensure that your angle of insonation is 0 degrees. So that's the sphenoid bone, is a bonish. Then you'll find that this vessel which runs inside is what we term the MCA. And you can see when it is normal, it should have high resistance with reduced end-diastolic and a high PI. When it's now doing this, whereby you can see that there's an increase in the end-diastolic, it's now becoming abnormal. It's now showing a trend towards redistribution Okay, so those are other images of the MCA, which I believe all of us should be able to competently perform. Then the ductus venosus, which is a tricky one, is one which can be imaged in the transverse or sagittal section of the fetal abdomen. How do you identify it? It's one of the shunts. I believe we all know that the fetal circulation has got many shunts, and one of them is the ductus venosus. As the umbilical vein turns into the portal sinus, it continues as a shunt to join the IVC so that it prioritizes the fetal heart with oxygenated blood. So it's a small vessel and it has got an alizing appearance that is a mixture of orangish reddish color. And this time you don't use 2 millimeters for your sampling gate, you use 1 millimeter to cover this small vessel. And the angle of insonation should be less than 30 degrees, preferably 0 degrees. That's the small vessel there, which is the ductus venosus, as the umbilical vein is turning into the portal sinus. And it has got the molar tooth appearance. And what we were referring earlier on when we were talking about absent or reversed A wave is that depression. So that's systolic, that's diastolic, and this depression is the one which we refer to as the A wave. Those are sections now in the, here, it's now in the sagittal sections showing the same vessel. So in summary, in terms of technical considerations, when you are doing these Dopplers, first and foremost, you have to obtain a very good 2D image. You need to verticalize the vessel, which is, some of these things are more practical. How to verticalize the vessel to make sure that you are scanning at almost 0 degrees. You need to adjust the scale or the pulse repetition frequency accordingly. If you are scanning a high velocity vessel, then you should also increase the PRF. If you are scanning veins, you have to reduce the PRF. You have to adjust the baseline. The baseline is this one. You don't want it too high here, whereby it's chopping the waveform, and you have to play around with your Doppler gain. So in conclusion, preeclampsia, we have noticed that it's a major contributor to fetal growth restriction in about 40 to 50% when we're talking about our local cohort, which I mentioned earlier on. Then preeclampsia patients should be offered fetal growth scans every 2 weeks. And Doppler should also be done as part of risk assessment, whereby you look at the umbilical, the MCA, the ductus venosus, and the uterine artery. So what are some of my recommendations? I think every sonographer or radiographer who does obstetric scanning should be competent in doing umbilical artery Doppler, middle cerebral artery Doppler, ductus venosus, as well as uterine artery Doppler, in order to improve fetal growth surveillance in pre-eclampsia patients, so that we can reduce our high perinatal mortality and maternal mortality rates. So wherever we are part of the care plan. Let's not just scan for the sake of scanning and sending the report, but let's scan with knowing that these findings which I have found, they are important in determining how the monitoring should be done, so that we don't end up with many intrauterine fetal deaths, but we would have picked them earlier on. In conclusion, this is part of our fetal medicine team. We had gone for the World Congress in Spain, Alicante in 2018. And we learned so much as we got exposure to what's happening in the different parts of the world. And this is only fetal We are only dealing with fetal medicine here. We're not dealing with any other. So it's quite an interesting field. And we also got an opportunity to be in camera with the great man, Professor Kypros Nicolaides, as a group before he asked me to have a personal selfie with him here. I thank you.
Thank you so much, Mr. Zanga, for that wonderful presentation. I will open up, I'm not really sure how many more minutes we have left before Zoom shuts us out, although this was supposed to be a 1-hour presentation. But just quickly, I just wanted to make a bit of an emphasis in terms of, we've been taught about preeclampsia, but I think something that we need to take note of, we also need to know which of our clients are at risk of preeclampsia. That is really important, so that it always keeps us, our antennas, upright, and then be able to investigate. And which patients are we talking about? We are looking at those with chronic high blood pressure or kidney disease before they are pregnant. Let's also consider those that had previously eclampsia or that are obese. In terms of age, it does matter. Those that are above 35, that are at a greater risk. Of course, the ethnicity, which is African, there's that greater risk, the family history, as well as multiple gestation. So these are the things that we need to bear in mind. Then concerning what he has talked about, which is very cardinal, concerning the training, I want to urge a lot of people out there, all of us that are involved in this practice, if we are not able to get to a school and then practice in terms of the technique of being able to sample this vessel and that vessel, I would urge each one of us, because of the current COVID situation, if we could meet in smaller groups and then be able to exchange notes and then show each other how we can do this. And I think his presentation, truth be told, it could be an eye-opener to certain practitioners. So let's engage each other, more, ask questions. If you want to contact Mr. Zanga, I think he'll be more than glad to share more information concerning management of preeclampsia. So at this point, let me ask those that want to ask to unmute your microphones and then ask the questions. Thank you. You can now unmute your microphones.
Hello.
Good evening. You may proceed.
Okay. At what stage is the assessment of the MCA become significant? At what stage of the pregnancy does assessment of the MCA, is it significant at 20 weeks or it becomes significant from 24 weeks and above?
Okay, all right. So for the MCA, all these Dopplers, we still do them, like at the fetal medicine level, we perform all of them on all our patients. But when it becomes very significant is after 32 weeks, whereby now it's an indicator of the fetal hypoxia or acidosis. It's a pointer towards that. So after 32 weeks, it becomes, its voice or its significance becomes more pronounced. But still, even before 32 weeks, we'll still have to document it. But after 32 weeks, it now becomes a major determinant of decision to deliver or frequency of surveillance.
Okay. So you mean to say you can do MCA even at 18, 16 weeks?
Oh, all right. In high risk pregnancies, like at those ones which would have flagged for preeclampsia, the very early onset, we can actually do them even when we are doing the anomaly scan, though they are not going to really determine our decision, because we know even if we make the decision for delivery, it will not change. It will not change the care plan. But where it really becomes, like at our fetal medicine unit, we are talking about around 27, 28 weeks, whereby now we have reached our local age of viability.
Okay.
In the developed
you know where
world,
I'm coming from?
In the developed world, I think they are now even scanning, they are now delivering even earlier than our 27, 28 weeks, because our neonatologists locally, they say they can only take care of a baby who has reached 1,000 grams or 1 kg.
Okay.
That's the one which they are able to ventilate and help. But before that, locally, currently, we haven't reached the stage of helping.
Okay. The reason why I've asked this question is we are also trying to at least reach exposure of side effects of waves on the blood vessels of the neonat. So I'm thinking starting MCA around 15, 16, and the times probably you have to try 3 times or so before you get the correct one. If it's not significant, is it really necessary?
Okay, yeah, I get you. Around 15, 16, usually we don't do the Dopplers, usually from the 20.
Yeah, I think I just wanted to chip in on that one, because remember, like I think from the presentation, is that when we look at early onset growth retardation, we are looking at an issue of perfusion. So this is why the uterine artery is very critical in that regard. But then when we are getting to the MCA, we are seeing a process whereby from the uterine artery, umbilical artery, we could have seen signs that then we would then focus, I think, around 30 to 34 weeks. And I think that's where I think what Mr. Zanga said concerning the issue of delivery. So I do not see personally, like, I mean, from the literature that I've read in terms of the much benefits earlier than that in terms of
exactly.
Like it's of very limited value. So at this point, kindly allow me to let Mr. Chitumba to ask a question. I can see his hand is up. Then I think Dr. Verenga should be online, and he will come in after Mr. Chitumba ask a question. Thank you. Mr. Chitumba, then Dr. Verenga.
Hello.
Hello. Yes, go ahead.
Okay, Mr. Zanga, thank you so much for the powerful and enigmatic presentation. I have got a simple question to make here. When we are making assessment of the umbilical artery, as you said, according to the protocols, you did say that we are supposed to measure at the free floating part of the umbilical artery, which is fine. But what happens then when we have got cases like a patient with severe oligohydramnios? In those cases, how then do you do it, or how are you doing it at the fetal medicine unit? Do you still continue to measure the umbilical artery Doppler waveform, or in that instant you ignore it?
Okay, so the free loop, it's usually when all things are equal. So once we have a scenario where there is oligo or possibly anhydramnios, then we just measure it wherever, but take into consideration that possibly it could be compressed. Then we correlate it possibly with the other Doppler, the MCA.
Thank you for that, Dr. Claudius Verenga. You may go ahead with your question or contribution.
Hello, thank you so much, Chair, and thank you so much, Admire, for the wonderful presentation. I just wanted to come in and comment on the MCA to say, when should we start doing it? I think from Admire's first slide, you saw that Doppler is multiple application in the care of pregnancy. One of the most critical role of MCA, yeah, thank you so much. One of the most critical role, if you look at the table number 2, the one in blue there, you see where it is written fetal anemia, TTTS, and TEPS. In babies who are rhesus isoimmunized, iso-immunization and fetal anemia can develop as early as 16 weeks. So MCA can be done from as early as 16 weeks in that context. Number two, TTTTS can develop as early as 16 weeks. So this is why we bring all the monoclonic twins, monoclonic diamniotic twins at 16 weeks, so that we can do the MCA as part of screening for TAPS as well. Because TAPS can also happen at the same time that CTS develops at 16 weeks. So in terms of when should MCA be done? From as early as 16 weeks, it can be done. In the context of fetal growth restriction, if there is evidence that there is fetal growth restriction, more so in our country, where preeclampsia is so prevalent, and we are getting these women with preeclampsia from as early as 22 weeks, with severe preeclampsia, with the abnormal Dopplers, we still go on to do the MCA because it tells us information of how much the baby is suffering from hypoxia. So MCA can still be done as long as there's presence one of fetal growth restriction, or in the case of twins, where we are screening for both for TAPS, and also in the case of rhesus iso immunization, where we are screening for fetal anemia. Thank you so much.
Thank you so much, Dr.
Thank you for that
Verenga.
clarification.
Thank you so much, Dr. Verenga. I think there was another hand, I can't read the name, L and L. The other person that raised the hand, may you ask the question?
Yeah, good evening.
Good evening.
Okay, I would like to thank Mr. Zanga for a very wonderful presentation. My question goes like so. I wanted to ask that, is there any possibility of having a false positive examination in relation to measuring the MCA as a result of scanning conditions? And when I say scanning conditions, I'm talking about the length of the examination, pressure of the probe on the mother's tummy. Is there any chances of that affecting the values that we get, especially when it comes to the MCA? And if so, how can we manage that?
All right. Definitely, if you put too much pressure on the head, it can have an effect. So in terms of the real scanning, I think this one was just an introduction. I think in terms of the real scanning, in terms of each and of the individual aspects, they really have, there are more layers to each on how
on
to perform them, which I couldn't put in just one presentation. So definitely there are many other aspects, like I was talking about raising the face. There's a way in which you actually raise the face and so forth in order to identify the greater wing of the sphenoid and the different. So this one was just a teaser of the real thing.
Thank you.
Thank you so much. Is there any other question before we close the meeting?
Or on the ductus venosus, I just have one question on the ductus venosus. You know, ductus venosus and the inferior vena cava, they are very close to each other, and you can actually at times miss the ductus venosus. And apparently the ductus venosus is key in deciding whether to deliver the baby or not. How can we avoid pitfalls of ending up measuring the IVC instead of the DV?
Okay, I think for the ductus venosus, I think it's a matter of practice, because you can attack it in both. If you see that possibly it has not worked in the transverse, then you try to attack it in the longitudinal. So if you have been practicing long enough, I think it's a matter of practice. I think I can summarize it along those lines. When I started, I used to have difficulties, but the more I continued to practice, I discovered that it's quite doable. And the waveform, I think that tooth appearance is quite typical to the ductus venosus. So I think it's a matter of practice.
Yeah, I think just a small addition concerning the ductus venosus is that the other thing, like we saw from the picture, is that in comparison to the IVC or any other vessel adjacent, we'll see aliasing because of the, I think even the color, you can see that it will not look like the other one, even in terms of the speed. So you'd find like maybe the other vessels, hepatic or IVC, maybe like 40 centimeters per second, whereas the DV would be around 80 to 100 centimeters per second. So that's the other aspect. So once the speed looks a bit tricky, then you are more likely dealing with a different vessel. Then just based on your sight, if you see aliasing within that vessel, most likely, and if based on the technique, you've precisely tried to locate it, with that, you can definitely tell that you are now looking at the DV. And of course, the characteristic of the waveform itself, it would tell you that you are there. Thank you.
Thank you. Thank you. Thank you for that addition.
Thank you.
David.
If we do not have any other questions, I think at this point, I'll extend my sincere gratitude to Sir Admire Zanga for a very wonderful presentation. I would also like to thank Dr. Verenga that I wasn't aware that he was in the background and also coming in to still add to this body of knowledge. And to everyone else that made their time this evening to listen to this presentation, we are really grateful. The whole idea is that we shall keep at it every Thursday with these presentations. So if there are those amongst us that have joined us tonight, I kindly ask if you are willing to give us a presentation, kindly get in touch with me from any of the posts that we made from the various WhatsApp groups where I posted today's link. And this presentation has been recorded. I will share the link to those that would want to go through it again. And I do hope that because like Sir Admire said, this was a teaser. So in terms of the real meat, I'll definitely knock on his door so that he can come back and give us more meat concerning, you know, the actual technique and everything else to do with Doppler with respect to preeclampsia. But like once again, I said, I kindly plead those that are in practice, can we take it upon ourselves to perfect it through practice and reading so that we may actually be of value in terms of that patient that would need us, unlike just providing a report that is full of fetal, you know, biophysical parameters, head circumference and that, but which would not help in terms of the management of pregnancy. So if there's nothing else at this point, I would like to wish everyone else who joined us a very good evening. God bless. Thank you.
Thank you. Bye-bye.
Bye.